Hi, good evening, everybody. We are doing a webinar for nurses today. No doctors involved, and it will be a nursing subtopic. Ms. Wong has actually joined us before on doing managing stoma, but now we have extended to managing complex and difficult stoma. And this is because of special request. And she was a very good speaker, very, how do you say that, experienced in both clinical management and also training. So without further ado, okay, before we get to the talk, I would like just to say that our nurses CPD points, right? We give an E-cert, okay? And this E-cert is actually awarded by my company, which is Beating Hearts, and it is an how you call that, voluntary. Okay, so please wait for the E-cert. If let's say today is actually the webinar, you will get the E-cert 7 days to 10 days from now. It all depends on how busy I am and how busy my intern is. So please be patient and please look at the E-cert over and over again so that you will know, okay, that your E-cert is there. If you have registered, watch and registered for the E-cert, you will get it. We won't miss you most times. Okay. Okay, without further ado, please, Ms. Wong.
Okay, thank you, Dr. Betty. So I just start sharing my screen first, yeah?
Yes.
Okay. All right. Can see my slides, yeah?
Yes, can see your slides.
Okay. Yeah, a very good evening to all of you. Very happy to come back again today. Yeah, I think after a few months. Okay, this evening will be on managing difficult stomas and also enterocutaneous fistula. This is actually I will explain what is it. Actually, enterocutaneous fistula is not very common for many people. Yeah. Okay, the contents I will actually touch on the factors leading to difficult managed stoma and the problems related to stoma and also peristoma skin. That means the skin surrounding the stoma and also managing difficult stoma after knowing what is it, the problem, the factors leading to it. Yeah. After that, I will briefly introduce what is enterocutaneous fistula, followed by some clinical cases which I have done years ago. I will be just sharing it. Yeah. Okay. Yeah. I think talking about difficult stoma, you may be wondering what is a good stoma. Yeah. Okay. From one of the article by S.S. Strong 2016, it was actually mentioned that a carefully constructed stoma in an ideal location and an acceptable quality of life is considered a good stoma. So if it's a well constructed stoma, if you look at these two stoma here, you roughly know which is actually better constructed stoma. And also the second part of it is actually an ideal location. But the first one, the top one, you can see there's some skin folds around here. It will actually be very high risk for leaking. And the stoma that is sunken in usually will leak quite often and also causing the skin to break, as you can see from here. And whereas the other one have a very nice protruding stoma, but location may not be very ideal because this, if you look carefully, this stoma is actually at the groin. So if it's at the groin, fixing a stoma appliance may be difficult. And it may also quite often, because of the movement when the patient walks, it will lift off and also it will cause a lot of leaking, quite frequent. Anyway, I'm sure all the doctors wanted to try their best to construct a good stoma at an ideal location, but sometimes it is actually not very possible lah, yeah, because there are also sometimes a lot of factors like patient's factors, the surgeon's own technical skill, and also of course other condition lah, the disease process and all that. So sometimes very obese patients, for example, maybe the layers that the doctor have to pull the intestine up may be a bit more difficult to mobilize lah, or move from left and to right, or to move to the area that he wanted or she wanted. It may be also difficult to fix the area because the bowel that is becoming too short due to the thick fat layer of the patient's abdomen. So it may be also very difficult to reach and have a very well protruding stoma. Anyway, there are also other factors that is causing problem, like potentially arise maybe early post-op period or months later, whether the patient's changing the weight loss or weight gain and things like that. It can actually cause problem. Then of course, I think that one is related to patient's factor lah. And a poorly constructed stoma can actually impact the patient's outcome, and the caring for it will be very difficult and complex, causing a lot of
Miss Wong, can everybody hear you?
Oh.
Can everybody hear? Because there was a comment that Lim Yan Ping take no sound, but I can hear her very clearly. Everybody can hear her? Yes, can. So Yan Ping, you have to
check the either the earphone or something, or volume. Okay, thanks.
Thanks.
Right. So the risk factor to get a difficult handle stoma may be the patient's condition, either age, like they are getting older, sometimes there are more skin folds, more skin creases, because as you know, the stoma will be on the abdomen. If there are a lot of skin fold, a lot of skin creases, it will actually increase the risk of leaking. Yeah. And also patient body mass index, I mentioned earlier, too obese or sometimes too thin also may be very difficult for them. Yeah, nutritional status, the wound breakdown and all that. Yeah, other than that, maybe sometimes patients have got some respiratory comorbidity, like the smoking and all that. Maybe they have got cough very frequently, so they may actually end up with some complication, stoma complication like prolapse, or sometimes they may have got hernia as the result of the cough and all that lah, yeah, or heavy lifting of the things. Sometimes patients with diabetes and malignancy, the malignancy sometimes can actually changes the stoma, because it's like the growth is pushing it out or something like that. Yeah, diabetes of course is actually like sometimes they do get fungal infection and things like that lah. Yeah. Other operative specific one maybe depends on the surgery, whether it's under emergency list or elective list. If it's elective list, the patient have time to prepare. The doctors and nurses can prepare them. They the bowels are very clean and things like that. But emergency, sometimes all this may not be able to do. So it is it has got a higher risk of problem stoma. Yeah. And of course the location and type of the stoma also will be affecting. If it's location I mentioned earlier, it is sometimes the stoma, if it's at the small intestine, we call ileostomy. Ileostomy output is more watery. More watery, the chances of the stoma content leak out is higher, and skin excoriation of course will be higher as well lah. Yeah, comparing to a patient who have got a permanent stoma that is actually having very formed stool, then the problem is less. Yeah. Okay, then the next one will be actually we are looking at just now was a little bit more in general lah. Yeah, now we are looking at the problem from specifically to the stoma itself. Yeah, sometimes we may have got the skin topography or the skin surface lah, which is actually causing the difficulty lah. Like for this page, for these pictures here, you can see in the center here is actually a stoma within a very firm flat surfaces, which is actually very easy to manage lah. Yeah. Whereas if you look at the left side, you can see if this one is slightly, the stoma is slightly in the area that is slightly retracted, the surface is not even, so leaking tend to happen more often. If sometimes also when the patient have got some hernia, the surrounding abdominal plane may be a little bit more bulging. It is also like not so conform for the stoma appliance, so it may also cause some problem. The other problem is like the patient may be very near to the scarring area, umbilicus and all that. It will actually complicate the management. If you look at this one here, it will be more difficult because of the multiple folds here. Yeah. So any questions so far?
You continue?
Okay. Yeah, you can type in the chat box.
Yes, can type in the chat box.
Yeah, I will go through it whenever.
I will also prompt you if got anything.
Okay, thank you.
Okay.
The other condition that also can complicate or contribute to a stoma to make it difficult to manage is like the protrusion of the stoma. Say for example, if it's the second one here, moderately protruding, is very good. Normally is approximately about 1 to 3 cm above the skin protruding, but depends on what type of stoma. So if it's colostomy, this is quite ideal. Less watery output. Transverse colostomy maybe not so but if it's sigmoid colostomy or descending colostomy whereby the output is a bit more formed, this is okay. Whereas for ileostomy, with this length, it may not be very easy to manage also. For ileostomy, this stoma that is a bit longer, protruding more, or we call pouting, it will be easier to manage because the output comes out, the opening is facing down, and it will directly collected into the back and not to the surrounding skin. So it will be much easier. And of course, sometimes, very often, I think if you work in surgical ward, you may have seen the patient have got the stoma that is very flat on the skin. We call flush stoma, or sometimes retracted, even more pull in more. Yeah, all these are difficult. Yeah, and so understanding the stoma, the abdominal plane. Now we look at what are some of the common leakage problem. Yeah. First of all, I think I would say most of the time, patients who have stoma that is not very ideal location, or the stoma that is not very well constructed, will contribute more to this leakage problem. Yeah. Output consistency, of course, it will be also. Yeah, if the patient having an ileostomy, if they are not taking the correct nutrition, that means they are taking like porridge all the while, they don't take any solid food, maybe the output will be very watery and more difficult to manage. But once they understand, and usually about 2 weeks after the surgery, the doctor will allow them to take normal diet, or they take more solid, then the output will be less. And at the same time, our intestine also will, the small intestine will also take over the function of the absorption. Normally it's just absorption of the nutrient. But after the stoma is created, after about 2-3 weeks, the body actually take, the small intestine will take over the absorption of fluid as well. So it's not so watery, it will be easier to manage. Of course, skin fold will be a big problem for patient to manage, yeah, and the skin condition. Besides that, leaking problem, it can be also the product selection. At times, if the patient have got sunken stoma, or we call the retracted stoma, or even sometimes flush stoma, if you are using the normal flat skin barrier or the base, it may not work very well. So you need to select something that is more convex, with convexity, that will actually press the surrounding skin to go down so that the stoma can protrude a bit more. So if you select the correct appliance, then the leakage will be a bit less frequent. And of course, the third one will be the application. Sometimes you get all the correct item to use already, but when application, if it's not done correctly, say for example, if the skin is not clean properly, or the opening of the appliance is not correctly cut, you cut too big, the opening, it will expose the surrounding skin to the fecal fluid. It will cause the skin to break. Yeah.
So this leakage, right?
Yeah.
Can be very embarrassing and very difficult for the patient themselves to manage, right?
Yes, yes. It can be sometimes the patient, new patient especially, the moment they know it's leaking, they feel so embarrassed that if they're outside, say for example, they are in the town going to buy food or something, suddenly leaking, so they will forever don't want to go out. So
yes,
so that it can be that bad.
And okay, never mind, maybe you will talk about it later, so I better not ask because I don't have much experience. Okay, we continue first.
Yeah. So the next one is about, oh sorry, next one is problem related to the stoma length, how to manage. Yeah, if it's too short, like for example, this one is actually we call a flush stoma. If it's watery stool, it will leak to the side very easily and cause the skin to break. So what we can do is we have to use something that is with convexity. This is a convex skin barrier. Both are also convex, are different brand. So you can actually apply around here so that the convex area will press the surrounding skin to be lower and the stoma will protrude a bit more. And of course, better to also go with an ostomy belt so that it gives better support and it will prevent leakage. Yeah. So usually it will, in watery stool, we also advise them to use some skin barrier that is actually with extended wear. Most companies have got two types of skin barrier. Some are the normal usage for not so watery output. Some are heavier fluid. Yeah, so they can choose that. And also the ostomy belt will give them more comfort because sometimes output is very heavy, a lot, very watery. It may be also heavy and it can pull the bag off a little easier. Yeah, so these are the management. And the other one that is actually earlier the slide, you can see that can be prevented. But if the prevention is not effective or not done, so the patient will end up with skin excoriation. This is actually the skin break due to the output. A lot of time people will think this is actually allergy, but I have to mention here that even sometimes doctors say allergy, because it's actually not allergy. Most of the time, maybe it's more because of the stool that is actually the enzyme, the proteolytic enzyme that is actually causing it.
Don't worry. Don't worry if you have to say that the doctor is wrong. Yes.
No, I just mentioned because some nurses will, a patient especially lah, I would say is this thing lah, because sometimes when they see redness, they keep changing different product, so it is actually not that helpful sometimes lah. Yeah, they have to manage the problem. Say for example, when they have got skin excoriation, they have got a lot of pain, burning sensation, and also it become more frequently it leak because there's no skin for them to stick the new skin barrier. When there's no skin for them to stick, it will leak even faster, so it become a vicious cycle. The causes of this can be sometimes the skin barrier, or we call wafer lah sometimes. Yeah, the opening they cut too big. This one is quite common because sometimes the patient post-op, immediate post-op, the stoma may be about 60 mm. Say for example, the stoma diameter 60 mm. Over 1 week, 2 weeks, maybe it will reduce to 50. So it is a natural process that the stoma will shrink. So when they are not aware of it, so when nurses, when teaching patient, normally we will inform them, but sometimes patients don't remember, so have to reinforce, have to check with them again that when the stoma, every time when they apply a new appliances, after maybe 1 week, they have to recheck the size. If the stoma have shrunk, then they have to cut the opening a little bit smaller. Yeah, otherwise this will happen quite often.
Kelvin, you asked a very important question. How do you differentiate then allergy from this skin excoriation?
Okay. I have slides afterward to show you.
Okay, good.
It's at the back lah, so maybe I can explain a bit further with the picture. Yeah.
Okay.
Thanks for asking. Okay, and the other reason for excoriation can be the skin barrier or the wafer is not properly fitted. Sometimes when they just apply, they did not do the necessary like pressing it to make sure it adhere well, so it leaves some gaps. Then it will leak as well lah, and cause the skin excoriation. At times, because we didn't notice that the skin folds or skin creases, we did not use anything to manage the skin fold or creases, it will leak around the creases. Yeah. And of course, the other reason is sometimes when there is leakage, they say, for example, sometimes the patient using the skin barrier supposed to be normal usage is about 5 days lah, but by 3rd day it is already leaking because maybe the stool is quite watery and patient have got some skin fold. Once it's leaking, we will advise them to change the whole thing. They cannot like use some gauze or something to patch on top, which will actually make the condition worse, because if they use something to patch on top the skin barrier, the side, it will leak out from the side. If they use some gauze to patch, the gauze will absorb, and whatever output that absorb into the gauze is contacting with the skin, the surrounding skin directly. So the skin excoriation can actually extend bigger because of the output. Yeah. So this is important now. Once it's leaking, even though it's 3 days, they have to change it. Yeah. And of course, I think sometimes some condition whereby patient not very familiar, they did not clean their surroundings. In peristoma is actually surrounding the stoma lah. Yeah, the skin surrounding the stoma is not properly clean. It can leave all the residue there and cause the skin to break as well. Yeah, so all these have to be have to educate the patient or the caregiver. Of course, to manage it, you know what is the reason, then you remove the cause. If it's opening too big, then you need to remeasure. Yeah. And if it's like not properly fitted, then they learn the correct way. They have to do it correctly. Like if any skin folds, they need to use something that we call stoma adhesive paste or some other whatever stoma paste lah. Yeah, they can use that to fill up the uneven area. And also they need to actually, sometimes certain patient, we may need to use something that is called seal and all those. But of course, like skin, broken skin like that, it doesn't stick. So what we can do is we can after cleansing, dry, and then we need to apply some Stoma adhesive powder at the surrounding skin. Make it very thin layer, because very thick layer, it doesn't allow you to stick the skin barrier. The new skin barrier cannot stick as well. So make it very thin layer. After that, we can spray some barrier spray on top of the powder. Wait for it to dry. Then only we apply the new skin barrier lah. Yeah. So these are some of the ways that we can manage that lah. Yeah. Okay. Then. Okay. I can't see the last. Okay. Need to move this one. Sorry, cannot see the last line. Okay. Doesn't matter. Use belt lighting. Okay. Anyway, the next one is actually if the patient. Now I will go into other peristoma skin. Just now, very common one is actually the exploration. Other not so common one, I will also briefly mention, just in case you come across, like folliculitis is one of the very common. Folliculitis meaning is the follic because the.
Okay, you're a bit laggy.
Yeah, because of the repeated removal. Oh, sorry, my line.
Yeah, your line is a bit laggy.
Not clear, is it? Oh,
yeah.
Sorry.
It's okay. Expected. So folliculitis is actually the inflammation of the hair follicles.
Yeah, because of the repeated removal of hair from the follicles when you pull off the skin barrier or because of the aggressive adhesive. So to manage that, usually we will shave the stoma and be very careful when we shave. Just have to be going away from the stoma. After that, clean and dry. After that, we can use some barrier wipe to spray at the surrounding, so that when you pull off the skin barrier the next time, it doesn't pull off the hair follicles, the hair so easily lah. But normally they need to shave about every week lah. Yeah, after 2-3 days it will grow back again. And if it's very badly like infected or inflammation, sometimes some steroid spray will be used, but usually this one have to be through a doctor. Yeah, still lagging or still now? Okay,
good. Everything is fine.
Yeah, thanks. And okay, the other this come to the question just now, the tip reaction or any adhesive reaction. Yeah. So this is also called allergic contact dermatitis, whereby you can see the outline is very clear. So in this case or this case, you can see the material inside. Oh, sorry. The material near to the stoma, it is okay. The patient is fine with it, but it is the adhesive tape outside that is actually causing the sensitivity. Yeah, both also same. So you can see this is the allergy. Yeah, sometimes not just sometimes also can be the inside one. Inside one usually is less allergy because usually is hydrocolloid. Hydrocolloid is very hypoallergenic. Outside sometimes the tape, the tape is more, how to say, it contains something that is called acrylate. So some patient will be more sensitive to it, or even the bag, the pouch itself that is contacting with the skin can also cause the skin to become allergy. Yeah, so you look at where is it, and then you decide which one to replace. Yeah, maybe have to change to different type, or if they have tried everything. Some patients, they are very sensitive to all the adhesive. Then sometimes we do use some skin barrier, like just now the Silace skin barrier to spray, and then only you apply. Sometimes it works, but sometimes it doesn't. Yeah, depend. Of course, if it's very bad one, sometimes doctors will prescribe some steroid cream. Yeah, using steroid cream, there will be also some problem because it's a bit oily. It doesn't stain. Whatever that is oily on the surrounding skin here will.
Oh, she's laggy again.
Will cause the adhesive not to. Oh,
you were a bit laggy, yeah, but
okay.
yeah.
Maybe what I do is I will change to my I got hotspot, so maybe I use, because my home fiber maybe sometimes not so good lah. Let me try to use my
I think it'll be okay lah.
hotspot.
Literally once in
Now,
a while.
okay. Oh,
Yeah.
okay. Sorry.
Yeah, it's okay. No worries. It's expected.
So when we use the cream, we will advise the patient to apply it early in the morning, so that when there's not much of output, after that, let the cream to stay on the skin for maybe about 15-20 minutes.
Okay.
Or you hold the top.
Maybe
then
you
only
to your hotspot. Miss Wong, maybe you change to your hotspot. It's laggy again.
Yeah. Okay. Will do. Okay.
Sorry, yeah.
It's okay. Sorry, I got to.
Yeah, just give us a moment, please.
Okay.
Okay. Oh, I see. You think that it's mine that is laggy? Kelvin said that it's mine that is laggy.
Oh, okay.
Okay, possible,
Anyway,
possible. Okay,
Yeah.
means I have to change to my hotspot. I try my best. Okay.
So I can go back to the.
No, I cannot change. Because if I change suddenly, I have to switch on my Wi-Fi. Okay, I can find it now.
Okay, so this is complete. Okay, after we.
Hold on, sorry. I cannot. Okay. Sorry, forget it. Because if I change my hotspot,
just the skin barrier will do. Yeah.
Okay.
And then the next one is actually another condition that is called epidermal hyperplasia, meaning that the skin thickening around the stoma, yeah, is usually a bit yellowish gray or sometimes red brown, like wart, yeah. And all this can be very painful. It bleeds very easily, and it is actually quite common in urostomy. Sometimes can be seen in ileostomy as well, yeah. Urostomy is the output that is the urine, yeah, after bladder removal. Okay, so if it happened already, a lot of time you need to use a lot of accessory to make sure that the surrounding skin is level up before you apply the skin barrier. Otherwise, it will leak quite often. So this is actually because of the excessive skin barrier for too long. Instead of like recommended 1 week, they are using it up to 21 days, I've seen. So if it's too long, then the urine or the feces that is actually absorbed into the skin barrier come into contact with the skin can actually cause a problem like this one. Yeah. So then oops. So most of the time we have to ask them to remeasure and do the correct way, but they need to fill up uneven skin, yeah, uneven area. And yeah. Now the next one is actually about the alkaline encrustation. We are halfway through already, 9:35 minutes. 9:35, yeah. Okay, so alkaline encrustation is another condition that you may not see not very frequently. I also seldom see actually it happens in urology patient, urostomy patient in urology ward sometimes. Yeah. Okay, I have got this. The causes of it is actually again is prolonged contact with the urine. Yeah. And the skin barrier they use for too long, or the opening they cut too big. But usually this is actually more related to the alkaline urine, because when the patient have got UTI, their urine tend to be a bit more alkaline. So when they have got alkaline urine, it stays at the site here. It will cause it has got some residue here. After a long time, it becomes very thick and a bit hard. It looks like more like the crystal that you really can touch. It is very hard. Yeah. So to manage this one, we will add 1 or 2 drops of the vinegar into the cleansing fluid. Maybe your cleansing fluid will be about 200 ml. Or 100 ml, you just put 1 or 2 drops of vinegar. In the hospital, we use acetic acid can also, yeah. After that, we just use it to clean off. After cleansing with the vinegar water, we have to rinse it with some clean water, yeah, either clean water or yeah, filter water or whatever. After that, they can apply the skin barrier as usual. Yeah, if there is some skin break, then the usual thing they have to use some Stoma acid powder to apply to the site, and some paste here to fill up uneven area. And usually patient, if they have got UTI, if they are not contraindicated, we will ask them to increase the fluid intake, yeah, to clear off the urine, so that their urine is not so much of a residue inside. Yeah. And vitamin C, it is actually a bit controversial. Some say it's helpful, some say no. Same goes to cranberry juice as well. Yeah. Okay, this is actually the alkaline encrustation. Now the next one, this one is necrosis. You don't see home patient having this, you very seldom. In the hospital, post-op, immediate post-op, this is actually considered early complication. Usually within 1 or 2 days after operation, yeah, it's due to deficient blood supply to the intestine here. Sometimes it can be the excessive tension on the mesentery, or they are trimming a lot of the mesentery, so it causes less blood supply to it. Yeah, this one. Normally nursing care, we don't do anything except that we inform the surgeon. We can make sure that the patient is using a bag that is transparent, so that you can observe, and also to cut the opening that is correct size, so that it doesn't constrict further. Yeah. And documentation is important. Of course, it will be patient will require surgical revision if it's not able to salvage lah. Sometimes if it's just a little bit of the necrosis can be salvaged, but if it's like this one here, normally the patient have to go for surgical revision. Yeah. Okay, now is it too heavy for you all? Actually not very common complication lah, but you may come across lah. Yeah. Okay, now this one is about the not peristoma anymore, but more related to the stoma. Yeah. Okay, this one you may see more often because peristoma hernia also can cause difficulty for you to apply the skin barrier lah. Yeah, usually this one can be due to weakened abdominal muscle. Especially older age patient, normally after abdominal surgery, they are higher risk, yeah? And also sometimes can be also inadequate surgical suturing. So the intestine is actually finding a sac and it go into the sac inside the body, causing all the intestine actually accumulated inside, yeah? So it is quite common for colostomy patient, maybe about 18 to 40% of them, ileostomy about 9 to 22%. So you may have seen it, yeah. And to prevent this or how to manage, to prevent, normally go back to the before surgery the stoma sighting I mentioned in the earlier session, that it is actually a procedure whereby the ET nurses, or enterostoma therapy nurse or the surgeon will select a proper location for the stoma to be created before the surgery, not in OT, but is before the patient going to OT, in the ward whereby patient can sit up, can lie down, can bend, can actually do different position to let the ET nurse or the doctor to check where is their obvious skin fold and all those yeah. So that is actually done before surgery. And also after surgery, if they can do some light work at home yeah, but normally we will have to advise them not to carry any heavy object. Anything that is more than 5 kg is advisable not to carry, otherwise they may have a higher risk of getting the how to say, the hernia. In fact, I saw one patient about 3 months ago. She has got a lot of cats. She told me she got 40 over cats at home. She just carry those. She carry the feet. She carried the feet, and that time she was only about 1 month plus after the surgery. Immediately, the next day, she actually developed the hernia, which is actually quite rare. Normally, people develop hernia about 3-4 months onwards, but hers was like about less than 1 month, I think. So got to be very careful, yeah. And also, normally when this happens, actually it's not emergency, but they need to do manual reduction. That means the doctor or the ET nurse will teach the patient how to slowly guide the intestine back inside. When they're lying down, when they're relaxed, the intestine that is actually at the sac here will actually go in already. But sometimes they may need to guide it slowly with the hand, and it will go down faster. Yeah.
You can try to reduce the hernia by yourself.
Yes. For stoma hernia, yes, they can. But it will protrude out again. When they stand up, they sit up, it will come out again. So sometimes they do need some abdominal binder, or severe one, they need to go for surgery. A lot of time, doctors also don't do surgery because to start off is actually their weakened abdominal muscle. If they do relocation, it may be another hernia on the other side. Or if they do the same area, they do repair and all that with mesh and all that, it may also, it may not work very well as well. Sometimes they just ask the patient to manage until, if temporary stoma, manage until the stoma closure, or sometimes it's like the closure will be bring forward a bit earlier. If permanent stoma, then a bit more difficult. Yeah, they have to have it for life. Yeah. Oops. Okay, then they also need to use some appliances or the skin barrier that is more flexible because it's more rounded now. So if you use the normal one, maybe it doesn't follow the contour and it will come off easier. Yeah, and of course the binder binder they can actually I check from Lazada. Actually Lazada have yeah. And also, there are many types. The appliance that is more flexible can be more conformable. Okay, and also observe if there's any changes in color, then they have to actually inform, or they have to go back to the hospital to see doctor. Okay, the next one is actually prolapse. Prolapse is also something that you may see in your course of work. Not that common, but you can also see it. Usually it's also quite similar to hernia, is due to the weakened abdominal muscle, and at times it's because of the opening of the stoma. They not this opening, when they do the surgery, when the doctor do the surgery, that time the incision, the intestine, that it comes out, or sometimes they are doing it that time a little bit bigger, is because the patient's intestine was very distended during that time. Immediately after surgery, 1-2 weeks, it reduced very drastically. So when the intestine reduced a lot, maybe there are more space at the side, and it can actually, after a long time, the patient can actually have got this prolapse happening. And it can be also sometimes the disruption of some internal attachment that is securing the bowel during surgery. One thing that patient can prevent is to prevent lifting heavy items. And also besides that, they have to, if they are smoking, got to advise them not to smoke. If they have got cough, they need to make sure that they have their treatment early. If chronic cough, it also can cause the prolapse. So this is actually in about 10% of the patient with loop stoma. And okay. Then to manage this one, normally the patient will get very frightened because of the intestine that is protruding out longer and longer, and they will actually they get very frightened. You have to inform them this is a complication. It is not an emergency usually, although it looks like very frightening. So normally what I do is, when the patient call me, I will just check with them when is their next appointment. If their appointment is like within the same week, then they can wait for their appointment to go and see doctor. If it's like too long, way one, then we'll advise them to go and go to the A&E to get appointment to see the doctor. Meanwhile, they have to observe the color changes. If it's like prolapse too long, and this sometimes there will be some the stoma become bluish or blackish, then it's quite dangerous. It's emergency. Otherwise, if it's remain red and then not getting too long, then they can actually the same thing they do the manual reduction as well. At times when the portion of the stoma is hanging out too long, it will swell. So when it is swollen, it doesn't go in back very easily. So what we do is we advise the patient to to reduce the swelling. Normally they can go to the hospital lah. The nurses can do for them. Surgical ward nurses will know. They can put some sugar on top here to actually have some do some reverse osmosis to draw the fluid out so that the stoma will shrink. Then it can reduce back. But most of the time when they lie down for about 15 minutes, then usually the stoma will be reduced back lah. But if it doesn't reduce back, if it's more than 1 hour, it is hanging outside. Normally, it is also something that they can't. They have to go to hospital lah, because it's like irreversible. Yeah. So these are the things that we will advise the patient lah. Yeah. If the prolapse is out a bit, like say for example 1 inch, 2 inches longer than usual, they still can how to say, they look at the appointment. If within the same week they go and see doctor, it's still okay. But if it's like a bit longer and it doesn't go back in, then they go and see the doctor in the hospital, either the doctor's appointment or the emergency department. Yeah.
Did you say sugar?
Yeah, sugar put on top here. Normally a bit messy if they put the sugar just on top here, also can. Normally what I do is I put the sugar, I make the very thick sugar paste. I use the gauze to absorb the sugar paste. I wrap around the stoma, and then it will reduce back. After that, but most of the time when they lie down for about 15-20 minutes, the stoma usually will also be a bit more relaxed and go in back, but not totally gone in. So if it's swollen, then we use the sugar. If not swelling, no.
Why sugar? How does it work?
Reverse osmosis. That means the sugar will draw the fluid. Yeah, draw the fluid out so that it slim the
I see.
say,
so that it will shrink inside.
Yeah.
Oh, ingenious. Learn something new every day.
But a lot of time patient after a while they also they just leave it like they just lying down. If can push it back in, they push it back. If cannot, some they just leave it outside because it cannot be reduced back. Some of them they just live with it until the closure lah. Usually the doctor will check lah and see whether they are suitable to go in for closure or not.
Okay, I need to ask how many more slides you have.
Okay, it's 9:52. I think not many already.
Okay, come quicker.
Okay, yeah. All right. So this is to manage this. Other condition like stenosis also not very common. It will be sunken in, so similar to the flush stoma management as well. Yeah. So I won't go through detail because it's not common. Some of the clinical cases that I've done before maybe give you some idea how to manage. Yeah. This one is actually the patient have got irritation from the surrounding skin. Now, she's 65 years old. When I saw her, that time was 4 months post-op. Yeah. She was not using any ostomy appliances that time. She's using some rag to cover. She doesn't go out of the house because she's very shy, smell also. So she got very poor personal hygiene. She got also financial problem because of that. So after that, I actually asked the ward that time, I think.
So she doesn't use any bag?
No, yeah. Luckily hers is not so watery. It's a double barrel. It's something like a bit more semi-solid. So refer to welfare department for some financial aid to get the appliances. She uses a two-piece system. After that, no more skin exploration. Yeah.
Oh.
Okay. Yeah. Then this is another case that I managed also many years ago. These are the 1998 cases I did. Just now one also maybe around 1998. So this lady is Madam Y, 81 years old. She had Hartmann's procedure done. Have a permanent stoma actually, yeah. She got very severe skin excoriation when I first saw her. This one is already okay. Then because of the skin fold, if you see this one, you actually cannot imagine when she sit up, it was like that. So how to put the barrier? Yeah. So it's something like impossible to manage for her. Yeah. So after that, we actually use some convex ring. That time the convex skin barrier is not available yet. We only have the convex ring that is something like this. I have to push it into the skin barrier to make it a bit more protruding. Yeah. After that, she okay, but she got some fungal infection. So after that, okay lah. Yeah. Okay, next is actually suffer from familial adenomatous polyposis. Is actually a genetic condition lah. Yeah, familiar condition lah. Yeah,
Sorry, I think my sorry, my part was not stable. Okay, go on.
It's actually there are about millions of polyps in the intestine. Yeah. So this one long after about 15 years, it will turn cancerous. So normally before the 15 years, they will be advised to do surgery to remove all the large intestine. Yeah. Okay, total colectomy done, and then end up with the ileostomy, but luckily hers is temporary lah. Yeah. So if you look at this one, the incisional line is something that I don't see in any other patient. This is one particular surgeon that do this incision.
It's so weird.
The output was very watery, and okay, if you look at this one here, you might be thinking the whole thing is the stoma. In fact, it is not. The stoma is here only. All those areas are actually skin break.
I see.
Very badly skin break. Then after that, we put the powder, we put the paste. That time I don't think so. I have seal also. I put the paste, then over here because of the navel there, so I just cover with something that is called duodenum. Then after that, we apply the bag lah. Yeah. So this is how I manage for this case. And another case, this one is very badly excoriated lah. This one I also don't know what. It is not the appliance. It could be some. She was receiving some radiation. It could be something from there or something that they apply on top lah. I'm not very sure. So after that, the doctor prescribed some steroid cream for her. It actually responded lah, so it's quite good after that. I don't have the picture after that, sorry.
But isn't the surgical scar a bit slanted to the? Is it because of the
picture, no, the picture we are taking from this side. Maybe.
Oh, I see. Okay.
Yeah. Okay. Then another one prolapse. This one is.
Oh, it's so bad.
Yeah. This one is the internet picture lah. Yeah, this is a real patient that I took. Prolapse until it's like so big. Then the prolapse is a bit difficult in handling the application. We need to make sure that the adhesive is on the skin and it's not too big, it's not too small. The opening, if too big opening, that will expose the skin. Too small cannot fit in, so got to adjust from side to side. Yeah. Okay, another, I think almost finishing in this. So this one is another picture. You may also see quite often that the patient have got an ostomy rod. Applying this one is quite challenging for most people. So most of the time, this rod is for loop stoma. The doctor put the ostomy rod. is to prevent the stoma from sinking down. It is actually a temporary rod that will be used from about 7 to 10 days. After that will be removed lah. It's quite easy to remove lah. This one is actually swivel. They can just turn one side and then they pull out from the other side. But application of bag may be challenging. You can use one-piece system, you can use two-piece system, but when you use the appliances, you make sure that the rod is on top, not below. Below it will leak. Yeah, so this is important. Yeah. Yeah, if anybody wanted to know more detail, maybe you can. Yeah, if I don't have a step-by-step how to apply lah. Maybe I just check through that I don't have any step-by-step application. If I have later, maybe I can show lah. Yeah.
Yeah.
Okay. Now this one. Oh, I think time's up already. Now my enterocutaneous fistula is actually abnormal communication between the epithelialized surface and then to the intestine. So this is how it looks like. And this is another case that I managed.
Okay, wait, no, stop already. Stop already.
Yeah.
Okay, so basically, I think we stop here.
Okay.
I think then one session, next time we can do sessions where we do, I like the case presentation. Yeah, the case presentation is very interesting, more interesting than, you know, all the theory behind it.
Okay, can I have a lot of cases?
Yeah, that's right. I think we can do that. And I think when we do
cases,
yeah, when we do case presentation, right? The memory, the stick better also.
Okay, can.
Yeah. Okay. Okay, we will. Any questions? Any questions at all? Now, I want to ask the nurses, okay, whether you guys would, you see now we are doing a lot of doctors webinar and then just a handful of nurses webinar. But if you guys have anyone that who would like to give webinars, nurses, because it's more difficult for me to get nurses because all my friends are doctors. So if you have any nurses or you yourself want to try to give a webinar, we can arrange it. That's one. Two is that actually I am all these nurses webinar, right? I don't know much. So if anyone want to host the webinar like I am hosting now, okay, and you think you want to host it, we can also arrange that. Okay, so you can arrange if you are interested in hosting, okay, or being a moderator, and also if you're interested in giving a webinar for nurses, please just message me or email me and we can actually try it out. Yeah, I think it's a good idea so that you can have more learning sessions and not just on the doctor's learning sessions. Okay, we will stop sharing here and we will stop recording here.